name is Maritza Salazar Campo. I am a faculty member at the Paul Mirage School of Business. And you might be thinking, gosh, why is a business professor talking to us about this? And the reason is that this is what we're going to be presenting today is the work of a lot of experts coming together around the primary interest of keeping our kids safe as we restart this next school year. And so we convened people from CHOC, we convened individuals from all over our own campus, infectious disease experts, pediatricians, public health specialists, individuals who think about school equity and education. And of course, we've also worked with the Orange County Department of Health. So needless to say, every meeting had numerous interests, right? People from the School of Nursing have also been actively involved in our endeavors. So today we have a couple of individuals who I want to highlight in particular, and I'm going to go ahead and let them say hello and give you a little bit of background. First of all, Pamela Kahn, who many of you know. Oh, she just turned her camera off. Hi, Pamela. Can you just say hi to everyone? And, you know, for me, in many ways, what our committee produced, Pamela has been a real blessing in the sense of getting that information to you and getting your concerns to us as quickly as possible. But Pamela, if you can just say a few words about your role and your hopes for this upcoming school year.
Hi, everyone. Most of you know me. I'm Pamela Kahn, and I am the Health and Wellness Coordinator at the Orange County Department of Education. And as such, I work with 27 school districts and public school districts in the county, and I work with many private schools as well in the area of school health services and school nursing. And I want to thank everyone, all the nurses on the call who kept giving input, and much to probably UCI and CHOC's and HCA's chagrin, who we've kept sending corrections in even as late as this morning to the document. But I know I speak on behalf of all of our nurses and other school staff when I express our utmost gratitude to CHOC, UCI, and the HCA for all the work they have done. Remember, we had so many of these calls in the beginning of COVID. Julie, you want to mute? In the beginning of COVID, and that was so helpful in getting us to school, or not back to school last year. And now we're back at it again with updated student decision trees, this call, and this help and support will be ongoing. And again, thank you all so much at those agencies I mentioned for your time and your efforts that you have spent with us. Very, very much appreciated.
Of course. Thank you, Pamela. Dr. Zimmerman, if you can say hi to the and 23 people on the call, let them know who you are, what your interests are for the school year, your role in developing this document.
So I'm Christopher Zimmerman. I'm a medical doc and working for the Communicable Disease Control Program here at Orange County. And I'm the lead for the Safe Schools for All program for Orange County within the healthcare agency. So I think I've worked with many and talked to many of this group, and look forward to continue to supporting you guys to keep people safe.
Excellent. Thank you. I also see Dr. Felice Adler on the call. She's joining us from CHOC. Hi, Felice. I want to say hi to just if you can give everyone your background, how you've experienced COVID as a pediatrician. Yeah, just say hello to everyone on the call, please.
Hi, everyone. Thank you for being here with us. Thank you for all your helpful questions and suggestions that we're going to get to. I am Felice Adler. I'm one of the infectious disease doctors at CHOC. And obviously, the last 18 months have been difficult for us in many ways, both from a hospital standpoint, but also from seeing kids suffering because they have not been able to go to school. And so we're really excited to start the school year off correctly with all of your help and make sure that our kids can stay in school this year with the help of everyone that's on this call. So thank you.
Thank you, Dr. Adler. And Dr. Nakia Best, I see you are joining us. Nakia is your ally, and she's a nurse in our school. Nakia, would you mind saying hi and telling them a little bit about your role over the last year and a half on our committee?
Hi, my name is Nakia Best. I'm assistant professor in the School of Nursing, and I've just trying to be an advocate for school nurses and all the work that you all do, and making sure your voice is in the room when we're making decisions, and also kind of following the lead of Pam and Michelle DeHaven, making sure we get it right. And that's that. And also, my research is how we use data to show the impact that school nurses have on student outcomes. So if you need help with anything data related, just let me know. And I'll be glad to help
Excellent.
you.
Good. So there are two other individuals I want to introduce. I also want to really, I guess, with a lot of gratitude, introduce Michelle DeHaven, who has often been another voice between our committee and the realities of what your guys' day-to-day are. Michelle, if I can invite you to camera, let everyone see your lovely face and just say hello and tell us a little bit more about your role in the development of our documents. Oh, she might have a technical issue. Well, we'll come back to Michelle in just a minute. Dr. Cooper, for those of you who don't know, Dr. Dan Cooper is the reason that you have had all the tools that you've had over the last year and a half. He is the head of our Institute for Translational Science Award. And more than anything, he's just a true champion for making sure that people in our region get the information that they need, the care they need, and that we just do the right thing as a university, providing information and guidance. He convened us a year and a half ago and has stayed the course that kids are safer at school if we take the right efforts to mitigate. So Dr. Cooper, to say hello, a couple of comments to the group.
Yeah, hi everybody, it's great. Well, it is great to see everybody again, but I'm sad that we have to see everybody again. I just came from my CHOC clinic, and one of the things I love about my patients is that I really get a chance to talk to the kids and their parents about things like, are they willing to wear a mask? What do they think about, the school year coming up, vaccinations with COVID? So it sort of keeps us all grounded. And, my thanks is to people like Maritza and Chris and Charlie Golden and Nakia and Pam and Felice. This is just sort of what we do as docs and what we do as healthcare providers. And we're so glad that we've been able to work with all of you to put together the document that Maritza referred to. Over the years, we ended up actually writing 4 different papers that got published in a variety of journals. One of which is probably the most frontline paper on what actually happened in schools in terms of the SARS-CoV-2 infection. We have an NIH grant, which is brewing about whether or not there are long-term consequences, which we hope will get funded. The paper that I mentioned, one of the authors was Dr. Chuli Ulloa, and she's going to be highlighted in the journal Pediatric Research as a early career investigator. So that was a real kudos to CHOC UCI and Orange County Healthcare Agency who helped support that. And so anyway, I'll be quiet because we really need to hear from everybody.
Thank you, Dan. And thank you for the, as you can see, our committee has had individuals who think about clinical care, the research behind our advice. Everything that will be today is evidence-based, rooted in the literature and what we know of the virus as it evolves. Last but not least, we've had Michael Weiss, who is the VP at CHOC. And unfortunately, he and Chuli Ulloa are on vacation this particular week. You're here. Oh, wonderful. Thank you for being here, Chuli. But we have had Charlie Golden step in as well. So I'm going to quickly, if you guys can see Charlie on his, he's at CHOC as well. He is the executive medical director of CHOC. Many of the children in your schools might see, they might see Felice. They are wonderful at their job. They also have a hotline when you have questions, and Charlie can, if you can say a bit about that outlet for the nurses on the call. Go ahead, Charlie.
Can you hear me okay?
Yes.
Yep.
I'm sorry, I'm in clinic. I'm having to dial in from my iPad and I can't get my name to change. So you get to see my colloquial family nickname here. So my apologies for that. But we do have the CHOC sponsored 844 number, 1-844-GET-CHOC. And we have our phone nurses, and those phone nurses are also supported by a group of physicians that are backing them up based on being on call. Basically, we were able to, and we're really proud to help support the schools last year with questions that come up that had some clinical nuance to them. Obviously, we can't be providing point of care medical advice, but to help sort through some of the basic questions that one might see in the school setting, clusters of symptoms, or what to do with particular nuanced clinical situations, we're happy to be here to help support any questions that folks have. So 1-844-GET-CHOC is the number, and we're happy to have been able to participate in this effort to create this decision tree. I think that the one thing that Dr. Weiss would say that we all recognize is that no algorithm is perfect, that there's always going to be some clinical situation where there are outliers or, you know, the situation doesn't really fit the algorithm. And that's what we're here to help with some decision making on. So we're happy to be here to help support you. And please feel free to use the hotline when you need it.
Perfect. And last but not least, and I don't want to take more than another minute or two here, but Chuli Uyoya is on the call right now. And I just want to make sure everybody can see her face. She is your advocate at UCI in the clinic. She is available at any point. So Chuli, go ahead, say hello.
Good afternoon, everyone. Thank you for being on this call. As Marissa mentioned, I'm a pediatric infectious diseases physician scientist at UCI and CHOC, and I've been actively involved in the community throughout the pandemic, working on, as Dan Cooper had mentioned, looking at transmission of SARS-CoV-2 in schools, and then also looking at the immune responses in our children. And so I'm very happy to be here today to answer questions.
Perfect. So you might be thinking, gosh, why did she just spend 15 minutes going through who's on the committee? And the reason for that is that I want you to know that we didn't just slap together some drawings and some arrows and say, good luck during the school year, but rather we have spent probably a cumulative 30 to 40 hours deciphering, if you will, what is it that the CDC is saying? What is the California Department of Public Health saying? What do we see in a clinic? What's going on in our own community here regionally? And how can we distill that language into something that is interpretable, usable? And so one aim for this call today, despite the expertise, the experts that put this together, is we need to make sure that we can answer any question you have, either about the document that we've produced that I hope everyone has had access to, and see what else it is that you need as you prepare for school. Some of you as early as, gosh, next week, I believe, right? The 12th. So let's go ahead, and I'm going to ask Dr. Adler to take us through the graphic part of the document. I'm going to share my screen and this student symptom tree. You may raise your virtual hand if you have a question. You can also put a question in chat. Lisa Hinojosa, who is on the call, will be helping us to make sure we capture every single question. If in virtual time we don't get to, we will find a way to get an answer to you by the, in the next 24 hours or so. Okay, so I'm going to share this this document that we have here. Give me 1 second. Where did it go? Okay. All right, so this is the current student symptom decision tree. Many of you should be able to find it, I believe. Pamela, this is on a website currently, correct?
Well, I haven't posted it yet, but it has been sent out widely via all my listservs to everybody because we're still kind of in the process of developing it. But yes, it will be on my website shortly.
Okay, if you need it, Lisa, can you put your email in chat? And please email Lisa and we'll make sure you get it by the end of the hour. Okay, so go ahead, Dr. Adler, if you wouldn't mind just walking through the top portion first.
Okay, so the top portion is going to be really similar to what you were all following last year. So in this student symptom decision tree, we still have it divided into low risk, or what you might call general symptoms, or high risk, what we call the red flag symptoms. And the red flag symptoms are still the cough, difficulty breathing, loss of taste and smell. And so then under that, you see the line that says symptomatic and exposure to a COVID-19 positive person. It's kind of an and/or exposure, because we have pathways here that address if you're symptomatic and you've been exposed, as well as if you've been exposed and are asymptomatic, or if you're symptomatic without an exposure. So in the top part, we're looking at patients who are symptomatic, and the no means no exposure. So patients who are symptomatic with no exposure and have only one of the low risk symptoms, this is where it's going to be just like last year, where the patient gets sent home and is allowed to return to school 24 hours later after symptom resolution without fever reducing medication. Again, that's just for one of the low risk symptoms. Then in a student who has not had any exposure to anyone with COVID, but is symptomatic with 2 or more of the low risk symptoms or 1 of the high risk symptoms, that student is sent home and needs to be evaluated by a healthcare provider and has to have one of the following situations happen. Either the healthcare provider has to confirm that the student has an alternative diagnosis and give the student a note.
Actually,
well
Dr.
as,
Adler, I'm gonna pause you really quickly.
Yeah.
Let's stay up here for a
Okay,
second.
sure,
Right.
sure,
So
sorry.
the question has been raised. Gosh, you know, the Delta symptoms seem different than the original form of the virus. Are these, you know, and this is, I'm asking this as on behalf of everyone. How do we want to think through these 9 various symptoms?
So
Is this exclude the Delta variant? And
I do
Charlie,
not-
Dr. Cooper, Julie, anybody can answer.
what do you, so I don't think this excludes the Delta variant. I mean, some patients with Delta variant have similar symptoms to the patients with the prior variants. You know, I think even with prior variants, there was a wide distribution of symptoms. And I think that, you know, nothing is going to be perfect that we can make. We're trying to do our best with the symptom decision tree to keep schools open, keep kids in school, keep kids safe while they're in school. And so that's kind of the background behind doing this. But I would definitely be interested if people have reasons why they think this is not appropriate for this year, or this is not going to work. And I'm interested to hear what my colleagues on the call have to say as well.
You know, Dr. Adler, I would just say, this is Dr. Golden, I would just say that we have to have something. We have to have some symptoms and some sort of way to parse out who potentially could have COVID and who may not. We certainly don't want kids that are sick to be in school, but we certainly don't want to be keeping kids home for 10 days or 14 days on full quarantine if they have regular seasonal viruses and they're better after 2 or 3 days. While there is myriad levels of presentation for patients that have COVID, particularly with the Delta variant, cough, difficulty breathing, and loss of taste or smell are still the most sensitive and specific, or I should say the most specific of the symptoms. And so that's why these have been chosen.
Good. So so in summary, our committee, wanted to provide you with something that looks familiar to what you were armed with last year and not overwhelm you with nuances. So we will say, gosh, these are generally the symptoms we want to keep an eye out for. Now, I'm also showing you page 2. And page 2 of our document also has some common questions. And so something here, there's a section here on general health and screening, ways to think through the symptoms you're seeing, right? So if you see, like, there's a question, gosh, what if somebody's lost one, taste but not smell, et cetera, et cetera. And you might say, gosh, you know what? Could something else be going on? And so if you have a student's health records, it's never a bad idea if they have a runny nose to go, gosh, is this a student that every year in October when I look in their chart, I realize they have an inhaler, they have an asthma issue. Maybe this isn't with just the one symptom, maybe this is a prior issue. There are a number of, there's a diagnostic process that you might want to go through before definitely saying, oh gosh, this is COVID, they should go home. And we have some of that language at the back of the document. Okay, so again, now we're going to go to the second half that Dr. Adler was starting us through. And you can see here that we're answering this question, symptomatic or we're going to make a modification here, exposure to a COVID-19 positive person. And again, this is within 6 feet of a COVID positive or clinically compatible person where they were together for 15 minutes or more within a 24-hour period, regardless of whether they had a mask on or not. Then we get to this question of, is this no or yes? And what's coming up in the Q&A committee is we're not doing modified quarantine, or you're defining modified quarantine differently than we're seeing the CDPH define modified quarantine. Dr. Zimmerman, others, any comments on the definition of modified quarantine and how we should be thinking about it moving into this next academic year?
So CDPH created a variety of options that they put forward to try to keep kids in school because, well, there's risks of exposed children being in school. There's also risks to them not attending school and balancing those risks and benefits. So one, as it's laid out here, if a child's vaccinated, and appreciate currently that's 12 and up. So that limits the primary school population quite a bit. But for those 12 and up, if they're vaccinated and exposed, they don't need to quarantine. But if they're vaccinated and they're sick, they should be, if they're vaccinated, sick, and exposed, which is where we're at in sort of this right after that middle yes, any symptoms, then they should isolate at home and get tested. So we have seen, particularly with Delta, that vaccinated people can become infected and can be contagious. And if people have symptoms, we want to keep those children out of school. But if they're well and they're vaccinated, they don't need to quarantine. Now, for unvaccinated children, if they're asymptomatic, there's an option for them to stay in the classroom during their quarantine. But to do that, the recommendation is
I have this student.
That first, this has to be an exposure in which both the person who is the case and this exposed child were wearing masks during the exposure. So if that's true, then that child could stay in class provided they're tested regularly. And the recommendation is twice a week with at least 3 days between the tests, that they avoid extracurricular activities. The intention here is to keep child in school where they're learning, but certainly, for extracurricular activities, we would say those things could wait for the period of quarantine. And you scroll down, there we go, thank you. Yeah, and the last, even in this modified quarantine where they're in school, they can test out if they get a test after the 5th day of exposure, and if that's negative, they could be out of this quarantine from after day 8. Or I'm sorry, after day 7. And I appreciate that this is a complicated set of options. And if someone doesn't want to be tested, they could choose to just do 10 days of out of school quarantine like we were doing, you know, in the previous term in last year's school year. So there's the option if someone wasn't wanting to get tested for this period of time, they could be excluded for schools for 10 days for their 10 day of quarantine. Now, the other option that's in here is if one or the other person at the exposure wasn't wearing a mask. So either the child who tested positive for COVID or the child who was exposed weren't wearing a mask at that time, then they're not eligible to stay in the classroom for quarantine. But they can get tested after day 5, and if they're negative, return to school at day 7. So
thank you,
again,
Dr. Zimmerman, for that. I mean, I think that you're a great communicator of very complicated information. And I just want to convey to you what's going on in the chat. There's a definite concern around the ability to manage and staff a modified quarantine, to keep track of the testing on the various days. And I know from our prior interactions, Dr. Zimmerman, you are well aware that the implementation of what is being passed down to us from the regulatory agencies is not going to be simple, and you're extremely empathetic, but these are the guidelines, correct?
And both of the modified options, okay? So the standard quarantine like it was last year was, you know, a child's exposed, they're home for 10 days. Provided they don't get sick. If they got sick, that would potentially extend that. But that was the standard quarantine, that exposed children were removed from school because they might develop disease. Okay, that's the backstop. Either one of these, where they stay in school or not for shorter periods of time, are options. Okay. And
so Dr. Zimmerman, what if a school says we're not doing modified quarantine? We can't pull it off, not happening. How would you have them interpret the chart? And this goes to anyone in the committee. Should they go directly then to child stays at home 10 days no matter what?
Yeah, if they can't successfully get twice a day, you know, twice a week testing done, then you're down to you know, or even the testing at after day 5, then you're down to the option that they're excluded from school for 10 days. And that's perfectly acceptable. You don't have to do all of these options. These are options. And I appreciate, and I've certainly discussed with people, implementing that in-school modified quarantine is a resource-intense process. It's there as an option.
Mm-hmm. Okay, so in summary, right, this document allows those schools who want to keep kids in school with a modified quarantine the means to follow this tree here. I don't know if you can see my cursor. If your school cannot handle it, it's not something you want to do, then you'll just have to think about the child will be home 10 days. And then the question is what can you do to provide continuity of education, right, while they're home, if making sure that they can have access to curriculum, etc. Now, one thing we want to highlight as well, because I'm seeing a lot of questions about vaccination status, etc. And the question about staff and the symptom tree, that's our next to do. We will be developing the same documentation for staff. But I want to make it really clear about staff and masks, especially in light of this one or the other person not wearing a mask directly. Faculty, staff, personnel, visitors have to wear a mask in schools regardless if students are. So if your district is doing professional development this week and vaccinated people are on a school property not mask, technically that's a violation of what the recommended policy is. And so for those, especially those teaching children 12 years old and older, it's unclear who's vaccinated, who's not. We don't yet have the legal rights, I guess, if you're vaccinated or not. We are encouraging schools to gather this vaccination material. We have some questions. We have Q&A down here. We do think schools should maintain documentation of immunization records, including COVID-19. Understand that it's going to be quite difficult to figure out among the teachers who have been vaccinated, among students who's chosen to immunize, etc. And so the general rule is inside, everyone should be masking, regardless of whether you're already going to the market now without a mask. In schools, it's a different story. Okay, let's see. Lisa, have you seen any themes of the questions that are coming through the chat? Things we should definitely cover?
Yeah, same with modified quarantine and testing. Their testing seems to be coming up quite a bit on, is it, you know, falling on the schools, or is this, do the parents go home and test, which also is an equity issue with, you know, some families won't be able to pay for testing. And so that'll be an issue. So I think that's something that's coming up quite a bit on how we are supposed to handle testing.
Okay, let's see. Doctor, do you want to talk about that one? Or Dr. Golden, we've generally.
Can I ask Chris a question about that, Maritza?
Sure.
Sure. Yeah.
Chris, for people, this is of great concern to us. This equity issue around testing that Lisa brought up. What will be, do you think, available as far as free testing for the situations where it would be useful to get a kid back into school if they could get tested? Do we have facilities? Will we be able to do that?
Certainly there are options for schools to get access to testing to some extent through us, as well as through the state has testing resources. There are also testing resources available, you know, outside of the school setting in the community. So there's a variety of options for testing, but whether a school can implement that gets into, you know, the resources they have. You know, it's not just having the test kits, it's having the bodies to do that and keep track of that. And I appreciate that those are challenging things. There are certainly options for that parents could be doing the testing on their kids. I appreciate that could be an equity issue. Again, there's the option to say, you know, we're not doing any testing. We're following this 10-day straight quarantine, no testing, you know.
Well, we're clearly going to be in for, you know, from the very beginning, I think we all looked at these guidelines and recognized that they're complicated and they're going to be hard to implement. And there's going to be a lot of learning that we all do on the way. Just keeping the data, I think, is going to be challenging for all the schools. I think all of us recognize that. As I look around, I mean, school district to school district, LA Unified is trying to get, they're trying to do routine testing. I don't know how they're going to do it. They haven't decided on which test yet, but my friends in LA Unified are telling me that they're going to be doing routine testing. Some countries are going to be doing routine testing. So, I mean, I guess the good news here is that there seems to be no clear single pathway, and that we're going to be learning, hopefully, as we move forward, what the best approaches are going to be. That's not satisfactory, but it's sort of what happens with a novel virus that has just changed some of its genetic makeup and is affecting people differently.
Right.
That's why these meetings are going to be very important in the future, because we'll be wanting to hear from frontline people what you're actually seeing when school starts.
Yeah.
So I want to take a moment really quickly and say, you know, we did see many of your schools opened, and I'm seeing comments in the chat about having the right plan in place, but then successfully executing it when you can't enforce a parent test, you can't make a principal keep everybody, you know, maintain social distance. And I want to encourage as much as possible, and this is me as a management professor saying, gosh, the more that every school can have a COVID action committee where the roles and responsibilities are very clear, which couple of people on campus are going to be skilled in the screening decision tree. What do we have our templates ready to go to parents in the case of a positive case? Do we have our county liaison who's going to report the case if we have one? Who's going to clean PE equipment daily, right? Really making sure that the plan of how this is going to work and that everyone is on the same page is there. And then in terms of setting the, encouraging the behaviors, right? That's also a team sport. The more staff, lunch personnel, the principal, vice principal are all on the same page, this is how we're going to mitigate our children people not getting sick and allowing children to stay in school. We know that face coverings work, period. And so the more we can keep the social distance and the masks up and worn correctly, right, we're going to be in good shape. We want to have a great school year. And so our committee was really thinking about how can we mitigate the likelihood of transmission. And so if you feel you're in a particular organization that hasn't quite found its shared plan, it's okay to speak up regardless of your role and say, hey, you know, can we pull together a quick conversation about how we're going to manage this? It would be a great act of leadership. Okay, let's see. Okay, so let's go to some of these other Q&As here. Another question about masks needing to be worn outdoors. What a great one. First of all, COVID can be transmitted outside. Absolutely, right? But it's less likely to happen if there's social distance. You know, masks are not required outside, but if you think children are huddled, never hurts to have them on. Dr. Cooper, Dr. Golden, Dr. Adler, we know kindergartners like to talk and laugh and scream and spit, and transmission can happen. But any thoughts about managing outdoor interaction, K through 12?
I can say something, and then Dr. Loa, I know, wanted to say something as well when we spoke earlier, but I think that it's going to be important to use common sense, just exactly like you said, Maritza, in this situation where if students are close together, if they're within those 6 feet, if they're, you know, sticking together in a small group for a long period of time, then masks are going to become more important at helping to prevent the spread, especially with how we define close contact. That doesn't differentiate between indoor and outdoor. So if kids are within 6 feet of each other for more than 15 minutes, that's considered an exposure, and that counts whether they're inside or outside. So if you think that they're gonna be in close contact for a long period of time, then it's worthwhile to encourage masks. While masks aren't being made mandatory for this coming year for students that are outside, they're also being encouraged by us. So I wouldn't say like it's everyone take their mask off, you're outside. It's, use good judgment about what seems appropriate given the situation. And Dr. Loa, did you want to add to that?
No, I don't think I had too much to add. I did just send out a link in the chat that it has like good animated photos of unvaccinated people and examples of outdoor activities where that one can participate in. So I think, as Dr. Adler had just mentioned, if you're kind of doing more independent activities, if you're socially distanced from other children and outdoors, then that makes not wearing a mask less lower risk for getting COVID-19. But if you're going to be in closer proximity, as kids tend to do, then I think the encouragement would be to try to wear your mask, especially for those higher risk kiddos.
I want to just comment on I've seen this now published. I see it in my clinic and the kids that I talk to, but the kids that haven't been in school have reduced their physical activity substantially. And there's some data now that there's weight gain, particularly among lower income kids. So we have been dealing with the pandemic of childhood obesity and physical inactivity. We know that the kids who are sickest with this disease are the ones who are overweight and obese. So we've got some guidelines that we can publish from some of our wonderful PE teachers about the kinds of activities that will stimulate physical activity, but at the same time maintain physical distancing outside. We'll get that, to everybody. Physical education is going to be pretty low on the list of the schools right now, but I think it's absolutely critical. And all the kids that I talk to in my clinic really miss school and miss PE, believe it or not. And, I just think it's really important. Last point is that we did develop a way of using very simple, non-obtrusive, non-identifiable approaches to assessing whether or not, how well a school is actually adhering to these principles. So we have trained observers. You go to a school, you can look at PE, you can look at classroom, you can look at communal dining, and we can give you numbers about mask covering, face covering, and physical distancing. And we're planning on continuing this. We published it in the paper that Julie and I and others on this call were part of. It's a very simple approach. I think it's going to be really important. It's one thing to tell schools you've got to do this. It's another school to see how much of this actually gets done. And we would have wished that, I think LA Unified now is going to start doing this, but it's something to think about as we move forward.
Dan, I really want to thank you for highlighting that lunch and snack are spaces where we might want to think about personnel to really encouraging physical distance when masks can't be worn, because if I'm not mistaken, that's one of the times Dr. Uyoya and yourself found transmission was most likely to occur.
Well, face covering was low. And in all the studies that have been done in the past year in hospital workers, Maritza, we found, and this is where hospital workers who are on the front line of taking care of inpatients who had COVID disease, the outbreaks that we saw in the hospital were exactly there. They were in the coffee breaks, and they were called break room breakouts. And this is
That's
true
a great reminder too for the way we think about faculty lounges and taking our breaks together and getting our time with friends and really thinking, gosh, this is a peak time for transmission. Good. Dr. Golden, can I give you the mic?
Thank you. Two things. Number one, a question was posed to me in the chat directly, asking about the use of basically props and other things for learning, and can we be using those types of things? Do we need to be sanitizing them, or do we need to have individual props for each particular learner? And I wanted to reiterate the fact that the goal here is to get kids back to school, number one, and to as much of a normal learning environment as possible, while keeping things safe. So different schools are going to have different levels of resources, and this is going to be another one of those equity concerns that all of us have. I don't know, and maybe my colleagues can chime in if they know of any particular guidance that comes from CDPH on this. But I would say as much as items need to be shared, that they should be sanitized in ways that can be done. If the school has the resources to have individual props for each particular student, that would obviously be best. But I personally would not recommend foregoing a particular learning activity because of transmission risk if items can be sanitized. So that'd be one thing. And again, I'd open that to my colleagues if they have any questions about this. And then number two is I just got a call from one of our doctors yesterday that a kid was sent to him for testing secondary to an exposure. And there was very minimal data on the exposure. And the mother didn't know about what the details were regarding the exposure, which raised sort of an interesting question. There was, if I think that the mom didn't know if the kid had a confirmed case of COVID or a presumptive case of COVID, if the kid was sick with just symptoms, and was therefore the child was sent home to get COVID tests because the child was exposed to the sick kid or not. So I think what I would recommend is, first of all, your primary care doctors around the county are going to be there, and they're prepared for a lot of visits because of kids being sent home because of an exposure. I would just recommend that while respecting students' privacy is absolutely essential, any data that you can provide regarding details around the exposure without getting crazy would be very helpful. So I think things like the student needs to be tested to come back to school because of an exposure to a patient who was symptomatic and confirmed COVID positive on Friday, August 9th. That's very helpful for pediatricians to figure out what type of test to use and how to proceed versus something much more vague than that. So if at all possible, including details like that when sending a child to their doctor would be advisable. Of course, if you don't have that information, then the doctor will figure it out and make a clinical decision at the point of care, but that kind of information can be helpful. So with regards to the props and things like that, I would love to hear from my partners and colleagues to see if there's any other guidance that anybody else has heard.
Yeah, we do have some information here about on the page 2, which again, we'll make sure everybody has this, which for certain surfaces that are, like food, where food is touching surfaces and people are interacting around food, we encourage that to be cleaned before and after meals. But any shared PE equipment, at least sanitized once a day, and anything that you think is communal, once a day seems to be what our infectious disease center at UCI, what they recommended, with, of course, the appropriate cleaning products. The question about shared pens at the front desk and whether those need to be sanitized every time, gosh, I really don't know the answer to that one, but it might be there with food items. I'm not, anybody have a thought on that one?
I mean, there is general cleaning guidance within the CDPH guidance for K-12 education. And it's really that once a day cleaning. You know, it would be different if you're talking about someone who was sick and tested positive, then you would want to clean things right then and there, as soon as we send that child home.
Perfect.
But in general, my understanding is that there's what are called fomites, sort of things that people handle, have been less associated with transmission.
Of these names are really.
Yeah. If I can ask you to mute if you're not speaking. Dr. Zimmerman, can I go ahead and have you respond to the feeling that, whoever, maybe Dr. Khan as well, Pamela Khan, the tracing is very time consuming, it's cumbersome. Often there's no, hey, we received it, hey, here's what we're doing with that information. What happens after all of that work is completed on the school site to report? And yeah.
Well, this is Pam. Let me comment on that. We have been receiving those kinds of comments and complaints, for lack of a better word, from the district, understandably so, because it is a burdensome process. We have been bringing those comments to the healthcare agency. They have tried to come up with some strategies that may help. For example, I responded earlier, possibly bulk reporting of contacts rather than each contact having to be, or potential contact having to be entered. The best I can say to you is if you are having problems, we are going to have a training on the 19th with the CDPH and HCA collaborating on that training for SPOT. I don't know if there'll be a lot of time for Q&A on that call. However, if you are having problems and concerns about Spot, I would encourage you to send them to me and I will forward them on, and we will let them know how it's going out here. One comment I will make is I was told that the healthcare agency is committed to sticking with Spot. They are not considering changing at this time. I don't know if that could be changed in the future, but that's where we stand right now.
Thank you very much.
Yeah, Spot's a specific reporting tool, and I think there's going to be additional trainings on that. There was a discussion today that we will work with the schools to try to make the reporting process as easy as possible. I appreciate both investigating contacts and reporting them. It's a lot of work, and who's a contact, it can be a challenging situation. You got to ask a lot of questions. Certainly when we receive that information, we reach out to those households to follow up whether people get sick, because the intent of that process is to try to prevent transmission to whether that's other household members or other children. So the case investigation and contact investigation process, it is a lot of work, but it is trying to impact how the disease spreads.
Perfect. So a couple of clarifying points that have come through the chat. Pamela Kahn wrote to everybody, right, we're going to define 3 feet for social distancing, 6 feet for exposure consideration. 6 feet is what is in our documentation, right? And I'm going to ask Dr. Adler to go ahead and use the last couple of minutes here. I'd like us to make sure we really understand the bottom part of the student symptom decision tree, especially as it comes to the 10 days, the 14 days, the testing at day 5, etc. So if Dr. Adler, if I could draw your attention, let's start with yes, and then let's go down to where it says unvaccinated.
Okay, so just to clarify, the yes is referring to if there's been an exposure within 6 feet or for greater than 15 minutes within a 24-hour period. This is regardless of masking, and this is in unvaccinated children. So in unvaccinated children who both of the children, the one that's infected and the one that's being exposed, if they were both wearing face coverings that were well-fitting and used correctly, and there's no symptoms in the exposed person, then that person qualifies for what we're calling the modified 10-day quarantine, and they're allowed to attend school in person if they wear a mask both inside and outside, and in that case, outside would be mandatory. If they test, what we're saying here is 2 times a week for the 10 days or at least 3 days apart, quarantine from any extracurricular activity for 14 days. However, this modified quarantine may end after day 7 if they test negative after day 5 from the last exposure. And we wrote here that students may return to extracurricular activities as well. That's if there's no symptoms at all. However, even if both people, the exposed and the infected, were wearing masks, but symptoms developed in the person that was exposed, then that person should be isolated for 10 days, regardless of test results. We would like them to get tested because we would like to be able to do some contact tracing. And obviously we would like them to make sure they are getting appropriate care.
Any questions about this, this particular branch? You can place them in the chat or ask it out loud. Okay, let me ask a silly question because something similar came up. When do I start counting, Dr. Adler, Dr. Cooper, Dr. Ulloa? Do I count at the, do I start saying, okay, day 1 was the exposure day, 2, 3, 4, 5. Can they come back on day 6, or how do we capture the days and the numbers?
So we usually count the day that the exposed person was exposed to someone who is sick with symptoms as that first day. Well, if they have no symptoms. And if the person they were exposed to was infected without symptoms, then we count, well, I'm sorry, let me start over again. So we count from 48 hours before that person started having symptoms. And if the person had no symptoms, we count from 48 hours before they have their positive test. So any exposures within that period, those people who had those exposures are the ones that are the quarantine recommendations are relevant for.
Okay.
Does that make
Now,
sense?
in Orange County, we have a lot of club soccer players, a lot of great football stars, a lot of kids who love swimming, and they want to get back to their training. When can they go back? Is it 7 days after? Is it, you know, the minute they get that negative test on day 5, they can get back out to, you know, lacrosse or whatever it is that they love to play? Back to piano lessons?
Dr. Zimmerman, do you want to answer that?
So if they're in quarantine and say on day 6 they test, and so day 7 they get the result, after day 7, day 8, they could return to their activities.
Did everybody hear that?
If they don't test out, then they're out of those activities for the quarantine.
2 weeks. They missed 2 games, 4 practices, 2 weeks. Everybody got that. So if a parent says, well, I don't want to have Susie test, it's painful. You say, fine, then you just have to know they may not play in the volleyball tournament after school. They may not go to homework club.
People have options. They can
People
choose
have
to
options.
test, and that can give them opportunities to stay in school or to return to activities sooner, or they can choose not to test, and then they're on a 10-day quarantine.
Right. And so, Sue, your question, you're absolutely right. If they don't test, then and they don't get that negative result, then yes, they need to spend the 14 days out of their extracurriculars.
So can I just clarify that the 7 days is when you're using the modified quarantine? And if you're not using the modified quarantine, you would still be at the 10 days?
You are correct. Yes. Isolation for 10 days regardless.
Thank you.
Sure.
I have a real quick question, if that's okay.
Please.
So I put in the chat, with our kids last year, a lot of them had the symptoms and they went to the doctor. The doctor said they shouldn't have to go through that test because it's too painful. So they just assumed if they had COVID, but you can't truly contact trace without a positive result, correct?
Who would like to take that question?
So if somebody calls, if the provider's calling them a case, they would likely fall into what we would call a probable. I mean, you know, that's, so a probable person would be if you were exposed, you had symptoms and you didn't test, you're a probable case because you were exposed to someone with COVID and then you develop symptoms. We think there's a much higher likelihood that you have COVID. Now it's a different circumstance if someone's sick, their provider says that they have COVID, but they're not getting tested. That's are they a probable case? We would like that person tested so that we know not only for how we manage that child, but how we manage the children around them. And that's why testing is important, particularly, you know, for individuals that are sick. We want to know, is it COVID or not?
Right. And that's the problem that we have. Sorry.
No, that's fine. I'm going to add to this conversation, and Sheila's correct. And we discussed this as a committee. Sometimes doctors will give a note and say they're clear. They without providing an alternative diagnosis. Dr. Cooper, can you respond to if you can make the comment you were interested in sort of how we managed interfacing with the healthcare provider, the testing?
Well, I just wanted to make a general comment, which is it's going to be a rocky start at the schools. This is a really complicated process. I see Dr. Zimmerman agreeing, and you've heard that Dr. Golden has a line. We'll keep our communications open. We'll reschedule these meetings. I know that Dr. Zimmerman will be open to queries. And I just wanted to make one general comment. In talking to parents and kids, I am a little concerned about the degree of emotion that parents have regarding the opening of schools. There are strong feelings on both sides. I've heard reports of parents sending notes to their schools saying, if a child shows up without a mask, it's virtually killing other children. And then the other side of the coin is, if you ask my child to wear a mask, you're damaging my child for life. I don't know what we can do about this, except that this group is such a wonderful group of people that I think when these issues come up about what do we do, we just fall back on being honest and saying, we don't have all the answers. This is it's still a new disease. It's 1.5 years old, and there's a new variant. We don't have a vaccine for the younger children yet. And if there is some way we can figure out how to communicate a sense of, hey, we're working on this together, let's just try to tone down and do the best we can, then we can muddle through it. Because I am worried about it's been so politicized, and you turn on the news and people are just really, really angry and frustrated, and I get it. But you guys are going to be in the front lines of this. And we've got to all come together and develop techniques we've got to be the really calm people as we move forward.
Can we also, really quick, because I know testing came up quite a bit. Can we clarify if saliva testing is okay? Because I know that was some of the questions for people. Can we use that as a testing? Because I think the painful other testing might be not an option for kids.
The CDPH and I agree that any FDA approved test is acceptable, and that includes the saliva tests versus the nasal swabs, the antigen test, or the PCR. So long as it's an approved test, we would accept the result.
Okay, so everyone, again, I want to just say thank you, and I want to ask some understanding, right? We really did try to read through all the fine print of the CDC, various important documents, and give to all of you an interpretation that was, had fidelity to what the regulatory agencies are saying, what our county is requiring, and then also make sure that that could be in a 2-page document as usable as possible. At any point, you should feel free to reach out to any of the trifecta, CHOC, the county, UC Irvine, and we will partner and help. If you're interested in having someone speak to leadership at your school, anything we can do to keep our children and teachers and staff as safe as possible, we're willing to lend a hand and partner. I'd like to thank Dr. Khan for inviting all of us to convene together and starting this important conversation. If there's a need to have these for a while, every week, we can figure out how to do so. You are not alone in this process. So with that, make sure you email Lisa Hinojosa your email if you want the documentation. We're going to make one or two tiny word modifications over the next 24 hours. So you can expect a finalized as much as possible document soon. Dr. Zimmerman, Dr. Cooper, any final comments? Dr. Ulloa?
Just to reiterate what Dr. Cooper said, I think this is this is challenging, and it's a particularly challenging time given what's going on with Delta to be starting school, and we're all aware of that. And I think we just need to work together and work through this. You know, we'll be a team.
And thank you, Dr. Adler. Thank you, everybody, for joining. Pamela, anything else this group needs to know from your perspective? The spot training, they'll know about when that's coming up.
Yep, I'm waiting for the link information from the HCA. We'll do that. I know that I had a lot of questions about the questions that people had been sending in prior to this. I knew we wouldn't have enough time to get to them because this could go on for a few hours. So hopefully we can meet and convene again and maybe address some of the questions that were sent in on the Google Doc, because those are pressing concerns that people have to deal with every day. So I will talk with the group and we will get back to everyone on when our next convening will be, hopefully soon. Thanks everyone for coming.
Thank you, everyone. Take care.